Hello and welcome to Conversations with Carrie. Today we'll be speaking about getting to know your patients beyond their diagnosis. This conversation is brought to you by the College of Health and Allied Development. You may contact them at 561 270 7383 or apply online at www.apply.chadedu.org. Now, when we clock in to work and take over our patients every day, typically the patient already has medication orders, nursing interventions, and other procedures planned. Unless, of course, that patient has a change in condition or is a new admission. When a patient is admitted, there are a series of assessments that are completed for the patient, one of which is the psychosocial assessment. Now, the psychosocial assessment looks at the patient's culture, religion, preferences, etc. Unfortunately, this does not encompass the whole being of the patient, and therefore it's important for us to have conversations with our patients and find out more about the patient beyond their diagnosis, go beyond their culture and get involved in knowing their cultural practices, go beyond their religion to speak about religious practices that may affect their care or their response or acceptance of care. Now, I'm sure you have a lot of stories that you could share with us, and we would love to hear them about conversations that you've had with patients that has led to a change in their plan of care, and of course, ultimately increases patient satisfaction. I'll just share one with you today. There was a patient that was admitted to the med-surg unit for uncontrolled diabetes. Now, during one of the tests, the nurse recognized that the patient was not taking breaths as frequently as he should, and this is called apnea. It is potentially life-threatening and it has to be monitored and treated. Hence, the patient was transferred to the ICU. When I took over the patient one morning, I noticed the patient was very exhausted. So I asked him, "How was your night?" He said, "How was my night? I haven't slept since I've been here because every time I try to sleep, this alarm goes off." This patient had high blood pressure, also had a high heart rate, so much so that he was on drips to control his blood pressure and his heart rate. So I explained to the patient, well, the alarm is there because you don't take breaths as often as you should, and when the alarm goes off, it prompts you to take a breath. He said, "Well, I'm a professional diver. I'm accustomed to holding my breath up to 20 seconds. This is something I've lived with all my life." Well, that was new information, and once this information was shared with the physician, we agreed that we would turn off the monitor and visually observe the patient during the time when the patient is sleeping, and if there is anything to cause alarm, like a drop in the patient's oxygen saturation, then yes, we would wake the patient up, encourage the patient to breathe, etc. So the alarm was turned off and the patient slept. Long story short, at the end of the shift, the patient's drips were discontinued. The patient's vital signs were stable, meaning his heart rate was now in normal range, so was his blood pressure. The patient was so rested and finally had a smile on his face. And the patient was observed for another 12 hours in the ICU and then transferred back to the medical surgical unit with appropriate follow-up for his apnea. So this may seem very trivial, but if you look at the big picture, the patient really didn't require ICU stay. The patient really did not need to be on all those drips if we had understood that this was something that was not sudden and may not necessarily require the care that was thrust upon the patient for the patient's own good. Okay, so share your stories with us. I'm looking forward to hearing from you. You may like, share, subscribe, and also comment and share your stories with us. Thank you for spending this time with me. Until next time, this is Conversations with Carrie.